that was also associated with any exertion. And similarly, like a chest pain, it was relieved by taking rest or sublingual nitrate. So what's the mechanism of ischemia? In our cardiac system, that's the epicardial vessel, and other is the microvascular structures. Epicardial vessel, the problem divided into the structural and functional parts. Structural problems include atherosclerosis, stabilized intramural hematoma, myocardial bridging, coronary aneurysm, and functional parts is the most common. That is, we often experience in our clinic. Is coronary vasospasm, either either endothelial dysfunction or vasospasmic hyperreactivity. And in the microvascular dysfunction, they often divide into structural and functional parts. In structural parts, inward arterial remodeling, capillary reflection, intravascular plugging, perivascular fibrosis, or extramural compression. In functional parts, impaired vasodilatation, endothelial dysfunction, and vasospastic hyperreactivity. They all ultimately leading to the ischemia. So if we don't treat the angina, so it has a 1-year mortality is 4%. With treatment, we can decrease to 1 to 3%. And these type of patients, they often experience major ischemic events in a year, 1 to 2%. This was the RATE registry, that is a European registry, that's a large registry. It shows the 1-year cardiovascular death is 1.9%, all-cause mortality is 2.9%, and cardiovascular death, MI, stroke 4.5%. So what is the pathophysiology? Pathophysiology start early in the life with initially microvascular dysfunction that can be we detect on the PET, CFR, and stress EMR. Then subclinical disease that can be detected by CT angio, cath, or intracoronary IVUS, and then ultimately leading to the decrease in myocardial perfusion. And we can detect that by PET, SPECT, and MRI. And that decreased perfusion preparation initially then lead to the diastolic dysfunction that we can detect by the echo, and decreased strength pattern that can be detected by the MRI and echo. And ultimately, even series of events begin with the systolic dysfunction, ECG changes, and ACS. So, what is the disease prevalence of coronary syndrome? This figure show iceberg pattern of disease prevalence. If we focus on the tip, that tip is a diagnosed patient with a coronary disease. Coronary disease, that is 50 to 70% in the male patients, and 30 to 50% are the female patients. But major portion that is submerged in the ocean, that is the major patient. These patients include non-obstructive coronary disease, are the patient who are at a coronary risk factor, are at a coronary risk, or inapparent coronary disease. These all large portion is submerged. That includes detectable demand ischemia, abnormal vasodilatation, जो coronary CFR हम करते हैं, vasospastic angina or endothelial dysfunction. So what's the natural history? So in the natural history, we often experience three type of patient in a natural history. First of all, those patients who diagnosed early and treated, revascularized, asymptomatic patient who has a high risk coronary disease, they undergo coronary revascularization, they have a very good long-term prognosis. Second type of patient who experience ACS, they were treated, revascularized, and they have a good pattern, a good prognosis as well. That's the blue line. And this is the red line. They have a high mortality, recurrent events. These are those patients who often experience ACS, but that they left untreated. So they have a high mortality, and they have often experience a recurrent type of um, ACS symptoms and very bad prognosis. So here are my two cases. One is patient A, that's a 40-year lady came to our clinic with a history of chronic hypertension that was controlled by SC inhibitors with good function class, again localized, non-radiation, and not associated with any stress. They have a normal with a normal ECG pattern, normal biochemistry pattern, and normal lipid profile. And type B patient is a 65-year male patient who often experience retrostoral chest pain, may relieved by taking waste or sometimes sublingual nitrate. He is hypertensive, diabetic, and he have a strong family history of coronary disease. He have a deranged lipid profile, ECG, having a significant ECG, STT changes. Other labs are normal. So we have two types of patients. Then how we will proceed for these patients? So always take a detailed history, ECG. Then on the basis of pretest probability, we have to suggest a specific type of non-invasive investigation for that patient. This paragraph show patient who have a typical chest pain, increased age, and dyspnea and exertion and other comorbidity. These type of patients and male pattern. So we have three patterns. That's increased age, male pattern, and typical symptoms. These three type of variables they have a high pretest probability. So this figure show how we will approach to our patient. First, we have to taking a detailed history, physical examination, ECG, and X-ray. On the basis of that, then we have to proceed. We have to suggest further investigation for the patient. On the basis of history and physical examination, if patient lie in a low PDS probability, then we have that is a if it's categorized in a low PDS probability that is less than 5%. So no further investigation for that patient, and just we have to advise for lifestyle modification and restrictor control. Second category is those patients who are categorized in a low to intermediate pretest probability, that is 35 to 50%. So we have to advise him as a CCTA, and on the basis of CCTA, on the result of CCTA, we have to further advise this patient and keep on GDMT. And fourth pattern is for those patients they are categorized on the high risk. So this is the algorithm for those patients who often experience ischemia, and but they have a non-obstructive coronary disease. So we have to follow the pattern like same previously. We have to take detailed history, physical examination, ECG changes. On the basis of ECG, we have to further evaluate the patient for the any specific investigation, non-invasive investigation. On the basis of that, we have to diagnose the patient with the obstructive or non-obstructive coronary. If patient is falling to non-obstructive coronary, we have to keep that patient on guideline directed medical therapy. If despite on guideline medical therapy, if patient experience often if patient is not relieved by his symptoms, then we have to go for the further investigation. That's we have a two type of investigation, that is abnormal vasodilation or the abnormal vasoconstriction. So what will be our initial management? As we have taking a detailed history, physical examination on the basis of which